Hello everyone. So today is the first demo class of our app Target200plus and we will be doing the whole OBG course in this app. Okay, so if you find it conceptual, concise, do come and join our course. Okay, so let's start with APH and PPH. As you all know that APH and PPH are the topics which are quite in demand, which are quite difficult to understand and which are very important from examination point of view. Needless to say, we can get 2 or 3 questions from this topic, isn't it? And we quite often get worried when we see these questions, when we see this topic. Why is it so? When we know that the topic is question is going to come from this topic, we should clear all our concept. Moreover, when you will be doing your clinical practice, you will see that these are the topics, these are the problems with which the mothers are suffering mortality. Yes, obstetric hemorrhage is the most common cause of maternal mortality, and a deep knowledge about this topic is must for us all. It will help us to save mothers. I think you can save 1 or 2 mothers in your internship as well. Okay, so let's start it. What is APH and PPH? So basically we will be because we are doing something very clinical here, because clinical questions are in trend especially from these topics. So I would like to start from the clinical symptom. That symptom is bleeding from the genital tract. Okay, so whenever there is bleeding from the genital tract or vagina in pregnancy, so yes, it gives goosebumps to all of us during the when the patient comes or when the we get question. Okay, so today we are going to solve everything about that. Okay, so bleeding from the genital tract or vagina in pregnancy. When this bleeding is in the early pregnancy, when this bleeding is in the early pregnancy, dear, this is most common reason of it is abortion. No doubt it can be ectopic or molar sometimes, but most common reason of it will be abortion if it is in the early pregnancy. The same bleeding from the genital tract if it is after 28 weeks. Now, what is the relevance of 28 weeks? See, after 28 weeks, the placenta is mature enough, isn't it? The placenta is mature enough, and placenta is big enough that it will cause such a high bleed that it will be life threatening for the mother, right? Bleeding is of course going to come from placenta, right? And unless and until it is a trauma, bleeding will come from placenta itself. So the placenta has become quite mature, and now the bleeding, if occurs after 28 weeks, it will be life threatening for the mother. And what about the fetus? You know that 28 weeks is the survival age for the fetus. Fetus can survive. Now, if the blood is not going from placenta to fetus, and if it is leaking, if the blood is massive, it can also cause fetal distress or death. So this is bleeding after 28 weeks is life threatening for the mother and life threatening to the fetus itself, because now it will not be abortion or it will be a premature, it will be a loss which cannot be saved. We can save the fetus, right? If we have a exact concepts about clear about the APH, we can save it. Okay, save the fetus and give the mother the baby. Okay, so this bleeding after 28 weeks is antepartum hemorrhage, and mind it, it is life threatening for mother and fetus both. So that is why a lot of question comes, and if the case gets mishandled, it can lead to maternal mortality. Okay, And when the question says that the bleeding from the genital tract is occurring after the fetus delivery, now then this bleeding is nothing but PPH. Because the fetus has delivered, now the lady is in the postpartum phase, and irrespective of the placenta has delivered or not, if the bleeding is occurring after the fetus delivery, it is PPH. Okay, so just you want to know that whether the bleeding is occurring in the early pregnancy, then it is most commonly abortion. Really, it can be ectopic or molar. If the bleeding is occurring after 28 weeks, it is life threatening for the mother, and it can be for the fetus itself, and it is known as antepartum hemorrhage, our today's topic, antepartum hemorrhage. But if the fetus has delivered, down this, if there is bleeding, it will be a postpartum hemorrhage. Now, the causes for antepartum hemorrhage, two main causes are placenta previa and abruption. Okay, so yes, we have to differentiate both of them. What are they? We have to diagnose it. And let's see. The rare cause is vasa previa. It is the rare cause. Let's what we will be following in gynae is, we will, before discussing any diseases, we will be discussing its pathology, so that we can activate our thinking process, and we can ourselves take out the risk factors, the diagnosis, the management, everything we should do ourselves by thinking, right? So this is the uterus of the non-pregnant lady. This is the uterus of the non-pregnant lady. As you all know, this is the upper part is the uterus, and this is cervix. This upper part of the cervix, which is highlighted with yellow color, okay, this upper part of the cervix. Now I have done it red, upper part of cervix. This is isthmus. This is called isthmus, upper part of cervix. And this, students, it lacks myometrium. It lacks myo, or you can say muscle metrium. Now, usually the placenta gets implanted in the upper part, and the placenta has a support of myometrium. What if the placenta is not on the myometrium, and when? Now this isthmus, it has no myometrium. Okay, this isthmus, it has lacks myometrium or no myometrium. It has no myometrium. Now this isthmus forms the lower uterine segment. Okay, this extends, this enlarges, and it forms the lower uterine segment. Okay, it forms the lower uterine segment. You can see that placenta is here in the lower uterine segment, and this isthmus is formed by the lower uterine segment, and here it is no myometrium. Okay, usually the placenta is on the upper part, and it has a support of myometrium. What will happen when the placenta doesn't get the support of myometrium? Myometrium is just the same for placenta as our parents are for us. Okay, we cannot develop fully if we don't get support of parents, isn't it? Right? We face lot of difficulties, isn't it? Similar way, now when the placenta is not getting support of myometrium, whenever a small force will come, okay, whenever a small force will come, small force like stretching of the uterus, or you can say kicking of the fetus, whatever, even on very small force, the placenta will start bleeding and get tear. Okay, placenta will separate and it will get tear. Okay, now see, for example, the fetus kicked it, and now this placenta starts separating. and now this will be bleeding. Okay, it will bleed like this. Okay, but mind it, it is a very small force. It bleeds it bleeds because it is not supported by myometrium. The upper placenta, the placenta which is in the upper part of the uterus, yeah, upper segment, this is upper segment. The lower uterine segment is not supported by myometrium because it is made from isthmus. If it is in the upper segment, if the placenta is, it doesn't bleed because it has a support of myometrium. Myometrium helps act as a shock absorber. Okay, myometrium act as a shock absorber. Now, because this was a very small force, but due to the lack of myometrium, this placenta has started bleeding. So, of course, after some time, it will stop also. Because this force was not a big force, it was a very small force, the bleeding will stop also. Such a bleeding which occurs and stop itself is what it's known as. It is known as warning hemorrhage. Warning hemorrhage, that in future there can be further bleeding. Okay, that all about the placenta previa pathology. Okay, so now let's see the abruption pathology. Then we will be doing placenta previa and abruption simultaneously. Now see, now here there is pathology in the spiral arteries. Now this is the placenta and these are the spiral arteries. Okay, spiral arteries, the pathology lies in the spiral arteries. Okay, pathology lies in the spiral arteries, and due to that pathology, the spiral arteries, they tear. Now let's see what will happen when this spiral arteries will tear. See, now the spiral arteries, they have teared from here. Now what will happen when the spiral arteries will tear? The blood will go into the myometrium, isn't it? The blood will go into the myometrium. So first thing which will occur when the spiral artery will tear, the blood goes into myometrium. Have any of you, all must be having one experience in your life when the blood has gone into your muscle, when bruise has occurred. In Hindi we say जब नील पड़ा था. ठीक है, एक एक्सपीरियंस तो होता है ना, जब गिरते हैं, जब मसल के अंदर ब्रूज होता है. सो इट इज वेरी वेरी पेनफुल. इट इज वेरी वेरी पेनफुल. द यूट्रस बिकम्स टेंडर. द यूट्रस बिकम tender. Okay, now because the blood is in the myometrium, this whole myometrium is flooded with the blood, the uterus become tender. Okay, or you can say there will be pain abdomen. Okay, now the fundal height will increase more than the period of gestation. Why it will increase more than the period of gestation? Because the fundal height will increase more than because this muscle has been flooded with blood. है ना, जब भी we get a bruise, our skin gets elevated because now it will be more, but not much more like polyhydramnios. It will be slight more. Okay, then the uterus, sorry, then the fetal parts will be not felt. Fetal parts will be not felt. Okay, the fetal parts are not felt. Got it? Now the second thing which will occur is, first thing was that the blood has gone into the myometrium. The second thing which will occur is there will be splitting of the see decidua, because spiral artery has torn here and there will be splitting of decidua. So the second thing which will be occurring is splitting of decidua, because blood will come here and the placenta will separate, splitting of decidua or premature separation or premature separation. This splitting of decidua will lead to fetal distress. Okay, will lead to fetal distress. On number third, it is that this splitted decidua will lead to number third. Now the blood will get clot. The blood will get clotted and it will go into the systemic circulation also. It will go into the systemic circulation also, into the mother circulation, into the systemic circulation backward. So when the clotted blood goes into mom circulation, it will release thromboplastin, and this thromboplastin, you all know, initiates DIC and is a very strong uterotonic. So the labor starts here. Okay, so the clotted blood, when it goes into the mother circulation, it causes DIC starting and it is a strong uterotonic, so labor starts. Number 4. Now after such a time when this has gone into the mother circulation, gone into the myometrium, now the blood will come out of the vagina. Now the blood will come out of the vagina, and this blood of course is clotted. It will be altered or dark blood. It will be altered or dark blood, or you can say APH has occurred, antepartum hemorrhage. So you can see that basically there are 4 things occurring simultaneously in abruptio due to the tear of spiral arteries. Blood goes into myometrium. It is making uterus tender or abdomen pain, or you can say abdomen tender. Number 2 is that it is splitting the decidua. So it is causing the fetal distress. Number 3, altered or dark blood color will come out and there will be APH or bleeding from the genital tract. Number 4, due to the release of thromboplastin. When it goes into the mother's circulation, there is starting of DIC and labor starts. So by the time a patient comes to us, patient has this clinical triad. Patient has this clinical triad. So that is why it is told that the symptoms, what are the clinical features of placenta previa? There is bleeding, which is painless, because they were very small forces which usually the mother does not respond, which usually the mother does not feel also, that painless and causeless. Whereas abruption has its triad, and what is its triad? It is made up of three. It is painful. Now I think you know it is painful, or uterus is tender because of the blood is from the spiral arteries is going into the myometrium. Number two is, anybody help me? Yes, number two is it is fetal distress. Now you know it is the due to the splitting of the decidua, and number three is the APH, altered dark colored bleeding. So this are, sometimes they can also give you the triad of, they can give you symptoms of DIC and abruptio, but rarely they give DIC or labor. Okay, but these three symptoms they will surely give you. There is no other than bleeding, there is no other symptom in placenta previa, and this blood going into the myometrium increases the fundal height, and the fetal parts patient will not allow to feel because uterus had fetal parts not palpable. Here there are no associated findings because placenta नीचे था, bleeding हुई और बाहर आ गया blood, that's it. And it is more so over a warning hemorrhage, and it is going to stop also, because now we know the force was very less. Otherwise no symptoms, just bleeding, bright red color bleeding, no cause behind that, and no pain with it. Whereas in abruptio there is painful, uterus is tender, fetal distress, and dark colored blood. Something big is happening in abruptio. No, so a lot of symptoms, right? Risk factor for the placenta previa. Here I would like to tell you, when the fetus is small, early pregnancy it is, placenta is also very small, uterus size is also very small. So at that time, the placenta is always in the lower segment. But as the pregnancy progresses, there is more growth of the placenta in the upward direction. This more growth of the placenta in the upward direction makes the placenta to go into the upper segment with the as the period of gestation and increases. Usually all the placenta they are in the lower segment initially, but as the pregnancy progresses they grow unidirectionally in the upward direction. Now this placenta will not grow if there is a scar in between, right? Then they will grow in the lower segment more. So any scar in the uterus is risk factor, even when it is cesarean or even previous cesarean or DNC, if there is a history of DNC. So any scar or any surgery on uterus will not let the placenta to move in the upper segment. This is one of the risk factors. The another risk factor is big placenta, as seen in the case of as seen in the case of as seen in the case of multiple pregnancy, or whenever there is big placenta, because the placenta has to adapt itself in uterus surgery or uterus. Any minor or major surgery of uterus will not let the placenta to move up, because this scar will be there and it will stop the placenta to move. No, don't move. Fibrosis is there. Now in abruption, there was problem in spiral artery. So you all know that in hypertension or preeclampsia, the arteries, the pathology is there. So the main risk factors which they will keep asking you is hypertension and preeclampsia. Okay, or preeclampsia. So in preeclampsia abruption तो होना ही है. Okay, then next is the another risk factor is yes, polyhydramnios, and then is trauma itself or thrombophilia. So how we are going to remember the risk factors? Polyhydramnios or over distended uterus. Big surgeries are hot. Big placenta surgery here and big surgeries are hot. So R means abruption is hot. Hypertension, over distended uterus and trauma, and for placenta previa it is big surgery. Other than this, we have to remember two more risk factors. One of PPH and one of preterm labor pain. There also I will give you mnemonic, so you will never forget the risk factors itself. आपसे कोई रात को भी आंख बंद करके भी पूछ लेगा, आप बता दोगे. So what are the mnemonics for the abrupt APH? Big surgeries for the placenta previa and hot for the abruption. Big surgeries are hot. Okay, one thing is this. Second thing is, because we know that when with multiple pregnancy or with age, uterus will get weak. So the placenta will not be growing with such enthusiasm as it grew in the first pregnancy, right? As it grew in the first pregnancy. So here in both of this, placenta previa and in both of this, it is multiparous and increase age. Multiparous and increases. Similarly, in the abruption also, the spiral arteries, they get weak with every parity and with age. So multiparous and increased age are common to both. Okay. Next, coming to the investigation. Placenta previa can be diagnosed only by ultrasound. Preferably it is TVS. Preferably it is TVS. Yes, I know PV is contraindicated, but in TVS the probe is quite far away from the os. So PVS is good mode, and placenta, as the placenta is in the lower uterine segment in placenta previa and just few centimeters away is the probe. So excellent view. Okay, so TVS is preferred and there is no bleeding while doing TVS. Okay, TVS is preferred over per abdomen. The diagnosis of abruptio is only clinical. Most of the time we are not able to see the clot in the abruptio by ultrasound. That is why lot of clinical questions are asked, because its diagnosis is clinical by the triad. What was the triad? Painful abdomen, dark colored bleed, fetal distress. PV is contraindicated बिकॉज प्लेसेंटा नीचे है, पीवी करेंगे प्लेसेंटा ब्लीड करने लग जाएगा, प्लेसेंटा से नो छेड़खानी. Okay, whereas when we will do PV here, the patient will be in labor, the patient will be in labor here. Okay, what is the management of the patient of placenta previa? The management of the patient of placenta previa is cesarean because the placenta is lying in the lower uterine segment. So if the fetus will come, if we try normal delivery, then what will happen? The placenta will come first. So if we will try normal delivery, so this placenta will come down and there will be hell of bleeding, right? This placenta will come out and fetus will come later, and then there will be hell bleeding and patient will be in immense danger. Okay, patient will be in immense danger. Just a minute, PowerPoint is not responding. On my side, the PowerPoint is not responding. Just a minute. Okay, so I think it's visible. Yeah, it's visible. So we were doing the management. So management is cesarean, and here because the patient is a high risk patient, so normal delivery is preferred over cesarean. Moreover, it is going to be very nice normal delivery, very fast normal delivery, because already the patient is in labor. The complication of APH in the case of placenta previa is PPH, whereas as you know, a lot of things were going in abruptio. The complication is DIC, and yes, PPH will be there because if the blood has gone into the myometrium, how it will contract properly. In PPH will not occur if the placenta will if the uterus will contract, but no, you know that the blood is there in the myometrium, so of course PPH will be there. Along with that, thromboplastin which was released will cause DIC. As you can see, this is the uterus in which the blood is in the myometrium. It is known as Covlier uterus. So it can be asked in your IBQ, image based question. Okay, just see here the purple or the wine colored uterus instead of this pink color. It is purple or wine colored uterus is bleeding in the myometrium, and its name is Covlier uterus. Okay, its another name is uteroplacental apoplexy. Apoplexy means anger, gussa. तो यूट्रोप्लेसेंटल apoplexy means यूट्रस और प्लेसेंटा में गुस्सा हो गए, ठीक है, इसलिए इट इज नोन एज यूट्रोप्लेसेंटल apoplexy. This is very important. Classification of placenta previa. Okay, so here one point was left, classification. Placenta previa classification we are doing. The name of the classification of abruptio placenta is page. Page, here you just need to remember page, and of course as abruptio cannot be seen on ultrasound, so it is basis of page classification is clinical features. Now let's see the placenta previa classification. This is very important. From the last two exams, the questions are asked on this. Okay. So now you can see here that placenta is quite away from the internal os. See, it is at a distance of internal os. So there is a distance. So this is away from internal os. When it is away from internal os but in lower uterine segment, so such a placenta is known as low lying. Okay, once again this much gap is there between the placenta and os. This is known as low lying placenta, low lying, and it is also known as type 1. It is also known as type 1. Both names are asked. Okay. See this placenta. It is touching the internal os. It is just touching the internal os. Just touching the internal os. So this placenta, which is just touching the internal os, is called as marginal placenta previa. Marginal placenta previa or type 2. Both names are asked in exam, marginal placenta previa or type 2. The another placenta is covering the os, but it is not equally on one side. On the left side it is more, you can see, but nothing on right side. Such a placenta which is covering the internal os and has the unilateral spread, not bilateral, such a placenta is known as partial placenta previa. Okay, and it is type 3 because it has a unilateral spread. You must be thinking, why ma'am we are calling it partial placenta previa? Because it is covering the internal os. Beta, with time the lower uterine segment stretch. By the time of delivery, it will be only partially covering the os. Okay. Now the fourth type of placenta is which has a bilateral spread like this. Okay, it has a bilateral spread, right, and it is fully covering the placenta, so it is type 4. It is type 4 or type 4 or central. So will you remember type 4 or central? Is it okay? So I think all the concepts are clear, which placenta is which. So that's all about the APH. One part is left, how to differentiate between APH and Abruptio. We will be doing it soon. Just let's relax and do the previous year questions so that we come to know whether we have gained something or not, whether we will be doing something correct in exam or not, right? A 38 years old pregnant woman. So can you see the age is high? I told you with increased age, the chances of APH increases because uterus and spiral artery, they get weak. And yes, multiparous is also a risk for APH. Is presenting with the history of recurrent bleeding. बार बार bleeding हो रही है. On examination, she is diagnosed to have placenta previa. Placenta previa, okay, multiparous, recurrent bleeding, and placenta previa is diagnosed on ultrasound. The type of placenta previa is depicted in the provided image. They are saying the type we have drawn in the image. So you have to tell what type it is. As you can see here, that here it is just touching the os. Okay, it is just touching the os. So when it is just touching the os, it's type 2 or marginal. It's type 2 or marginal. Okay, but don't worry, I will not be giving you type 2 or marginal in your test. I will be giving you type 1, type 3 or type 4 because I know now you know after doing this question that the placenta which just touched the os is type 2 marginal. Okay, here I would like to tell you that same question was also asked in FMGE Jan 23. So I always say get a hold on PYQ. Since this question has come in the January 23 exam, the type 1, type 3 and type 4 can come. So this is a old classification. This is a old classification. What is the new classification? The new classification is that this type 1, which is more than which is away from internal os, is known as low lying, and rest all other are these all three are called as placenta previa. No marginal, no partial, no central, because only in low lying we can do normal delivery, whereas in marginal, partial and central we have to do only cesarean. So they say, why to divide, why to use these terms when management is not different, management is same, right? So that is why they have an idea ki it should be low lying or placenta previa. But the questions are asked on all classification also, and last year only they asked you, and Neet-PG 19 they asked you, last year they asked you, so you should be knowing. So identify the placenta abnormality. So here they want to ask you what type of placenta abnormality it is. So the options were placenta accreta, abruption, placenta previa and vasa previa. So what happened in accreta? The placenta goes into myometrium. You can clearly see the very well myometrium and placenta good myometrium, and placenta is not going. So it is not placenta accretum. In abruptio, there is clot behind the placentum. Okay, in the upper placenta is located in the upper part and there is clot. So because there is no clot and the placenta is not in the upper part, it is not abruptio. In the placenta previa, the placenta is in the lower segment, which it is. So the answer is placenta previa. Whereas in the vasa previa, the vessels, here there are no vessels, it is a cord. So it is not vasa previa. So the answer is placenta previa. Don't do it wrong next time. Okay. Which of the following is a feature of placenta previa? Very easy pathology of placenta previa. Let's divide it. Small force separates small placenta, small low lying, or you can say lower uterine segment placenta, and bright red bleeding, small bright red bleeding comes which stops. That's all. So there is warning hemorrhage. Yes, the bleeding which stops on its own is the warning hemorrhage. Fundal height is more than period of gestation? No, it happens in abruptio when the blood goes into the myometrium. Uterine tenderness? No, it happens in abruptio when blood goes into the myometrium. PIC? No, it happens when the mother blood is flooded with the clot and there is release of thromboplastin which is there in the abruption. So placenta previa में क्या होता है? छोटा सा फोर्स, छोटी सी ब्लीडिंग, रुक जाना है, रेड कलर की ब्लीडिंग और कुछ नहीं, बस इतना, छोटी सी पैथोलॉजी बस, इसलिए क्योंकि वो लोअर यूट्राइन सेगमेंट में था, उसको उसके पेरेंट्स का सपोर्ट नहीं था. ये INS set November 22 recent year question. Clinical features. Not a feature of abruptio. Tender uterus, it is a feature. PIC, it is a feature. Painless bleeding, no. These two are opposite thing. When the uterus will be tender, how it will be painless? No, it will be painful. So the answer is painless bleed. Uterus fundal height longer than the period of gestation. This is correct. Let's see the next question. This question I added because I expect this question to come. Okay, it hasn't come in any exam. 34 years pregnant female at 36 weeks is coming. It is of increasing age. Okay. In emergency with a complaint of painless bleed, 36 weeks, patient is coming with painless bleed. Okay. Then fetal heart rate is PA is soft, non-tender, and fetal heart rate is regular. So all the indications are there that it is placenta previa. Next step. What is the next step? Now they have said that clinically it is placenta previa. But we have to confirm our clinical suspicion with ultrasound. It is must in placenta previa in a case of abruption because sometimes the clinical things can get wrong. Okay, and ultrasound is very easily available. We should get a stamp of conformity by ultrasound. So because you know that abruption is something very dangerous, it can lead to DIC. It needs to be managed by normal delivery, and whereas cesarean and placenta previa is something very mild and it needs to be done, cesarean is need to be done. So we need to get the confirmation of our clinical finding by ultrasound. So next step will not be cesarean, it will be ultrasound. Okay, here I would like to tell you, because I told you that in placenta previa there is warning hemorrhage and the bleeding stops. Now if the period of gestation is less than 37 weeks, and you know that in placenta previa the bleeding gets stopped, are you going to terminate the pregnancy? Are you going to terminate the pregnancy with one episode of bleeding? No. You would like to take the pregnancy up till 37 weeks. So, if the period of gestation is less than 37 weeks, and typically examiners say you 32 weeks, warning hemorrhage occur in a case of placenta previa. So, your management will be conservative. McCafe, Johnson regimen. What is there in the conservative management? We make the patient to do bed rest so that more placenta does not separate. We give betamethasone for the coverage of lung maturity of the fetus. And next is we arrange blood, because we know whether it is placenta previa or abruptio or PPH is going to occur, so we arrange the blood in this time. Okay, so here I would like to tell you, they always ask you some common sense question, that conservative management in placenta previa is not done in placenta previa is not done in, it is not done in the case of it is not done in the case of, can anybody help me? If it is a IUD, if it is more than 37 weeks, if it is the case of fetal anomaly, then in all this condition we don't want the time, right? Or if it is a case of fetal distress, and if the mother's bleeding is not getting stopped, or the mother has gone into the labor. Okay, so in all these cases conservative management is not done. When we don't want the fetus, why would we want the IUD fetus? When period of gestation is more than the, why we want to mature further? When it is a case of fetal anomaly, when it's a case of fetal distress, if mother is unsafe, mother is getting bleed, mother is going in labor, if the mother is going toward an unsafe time, why to do that? Now this is a great Now this is a great confusion, and I will make it very easy for you. How to differentiate between rupture uterus and abruptio? See, what happens in rupture uterus? Whenever the rupture uterus occurs, the fetus, the placenta, the amniotic fluid, everything comes into the peritoneal cavity. Rupture uterus means uterus has teared. Peritoneal cavity. Along with this, from the torn end of whatever ends of uterus or rupture, there is increased bleeding occurring, which is also going in the peritoneal cavity. So in rupture, all the products of conception from the uterus has come into the peritoneal cavity, and the bleeding is also coming into the peritoneal cavity. So a lot of things in the peritoneal cavity. So now let's see what will happen in rupture uterus, because you know that there is, in the previous cesarean, the patient is prone to rupture uterus, so they will give you a history of previous cesarean. Sometime a bad examiner does not give you, but surely the examiner will give you the history of multiparous. In abruption, the examiner will give you a history of hypertension. The examiner will give you a history of hypertension. Okay, examiner will give you the history of hypertension. Okay, on per abdomen, there is generalized distended abdomen, because in rupture uterus everything is coming, including the blood is coming. So abdomen will be generalized, distended and tender, whereas in abruption only the abdomen is tender at the site of uterus. But do you think the examiner will tell you only tender at uterus? No, examiner didn't tell us this. Examiner always tell us abdomen tender. So we cannot differentiate on the basis of this. Okay, this is a poor side. Okay, uterus contour not felt. Uterus contour is because everything has come into the peritoneal cavity, so uterus has gone very far behind in the pouch of Douglas. So how we will feel the uterus? So uterus is not felt, whereas here the uterus is felt. So if the examiner gives you increased uterine tone, it means the uterus was getting felt. Increased uterine tone, it means uterus was felt. It was tender. So then of course it is a rupture. And you know that fetus has come into the peritoneal cavity, so fetal parts will be superficially felt in the rupture uterus, and this is a very important finding. Okay, and here we cannot fill the fetal parts, because you all know that the fetus is inside a myometrium which is loaded with blood. In both of the cases, fetal heart rate is not felt. Now when this fetus is coming into the peritoneal cavity, IUD will occur. Okay, IUD occurs. So if they are telling you fetus heart not heard, it is same, because when the fetus is inside the myometrium, the fetus heart rate will not be felt. So I personally say you that don't rely on these findings. Rely on only fetal parts not felt superficially, or fetal parts felt superficially. Only this finding is important. Fetal parts, that is what is important clinically for us. Okay, because it is very easy. Fetus has come into the peritoneal cavity and we are feeling the fetus uterus, and such that is not there in any other in the abruption. In abruption we cannot feel the fetus, because fetus is there in the blood loaded myometrium. Okay, so this is very distinct finding, आर पार कर देती है ये finding. ठीक है. In the PV, this PV finding is very important because fetus has come into the peritoneal cavity. Okay, and one thing I would like to tell you, in both of the case the patient will be in labor. Okay, so in PV findings में पहले जो फील हो रहा था, हेड फील हो रहा था, अब वो नहीं फील हो रहा क्योंकि fetus has gone into the peritoneal cavity, so that is known as loss of station, presenting part not felt. Whereas here the patient is in labor, everything is felt easily. On ultrasound, the fluid and fetus is inside the abdomen is the finding. So just learn these three findings which are totally आर पार करने वाली condition. Fetal parts superficially felt, okay, loss of station, fluid and fetus inside the abdomen. Okay, so let us see the questions, and by that APH will finish off. This question has come into the FMGE June 21. Okay, it patient has come to emergency with pain abdomen. Okay, there is hypotension. Okay, now in abruptio there is blood loss, and in rupture uterus both there is blood loss. Pain abdomen is there in both. Okay, on examination there was abdominal distension. Fetal heart rate was not felt. Okay, fetal parts were felt superficially. Now I told you need to learn only 3 points. Fetal part felt superficially, loss of station, presenting part not felt, and ultrasound finding of fluid and fetus in peritoneum. So this is a case of rupture uterus. Okay. See next question. Pregnant woman with pain abdomen and hypotension. There was abdominal distension. Fetal parts के बारे में कुछ नहीं बताया. Because they don't told, so answer is abruption. Okay. G4P3L3 on PV examination, patient was in labor and cervix was 5 cm dilated. Doctor was not able to feel the presenting part. At 5 cm, the doctor is not able to feel the presenting part. What is it? It means the fetus has gone into the peritoneal cavity. So it is a case of uterus rupture. Okay. Lady with 37, again FMG question. Lady with 37 weeks of pregnancy, previous cesarean, came with low BP and tachycardia. On ultrasound, fluid is present in peritoneal cavity. Fluid is present, previous cesarean. So the answer is uterine scar rupture. Okay. Ectopic cannot be there because at 37 weeks ectopic का कोई लेना देना नहीं है. Eclampsia में they will be giving you Caesar history, but when fluid is there in the peritoneal cavity, it will be the uterine scar rupture, and laparotomy is the treatment. I hope now things are clear to you. Okay. See you soon in the next video. Till then, take care. Bye-bye.